Well, the ergots and the triptans were the first specific drugs for migraine treatment. They told us that they are very efficacious and that you can have very efficacious drugs against migraine attacks. However, they told us that there must not be a specific vascular action, but there must be any action we still do not know. So we learn from these drugs, yes, we can treat migraine efficaciously, but we do not know how and why they are efficacious. So this was the reason for further research into, for instance, CGRP antibodies. We learned that in primary headache disorders, that is migraine or cluster headache, CGRP is released from neurons in the brain. And we know that if we block the CGRP release, we can treat these attacks. There are different ways how to block CGRP. You can block the release, that are doing the triptans. You can block with an antibody, these are new drugs, and you can block the receptor. So we have different ways to block CGRP, and we know from pathophysiology that CGRP is the major molecule in migraine and cluster headache. Primarily, the CGRP antibodies work in any migraine or cluster headache patient. So there is no reason why it should not work in any patient. However, there are some patient groups which we treat very carefully. These are patients with gastrointestinal disorders because the CGRP antibodies can have side effects gastrointestinally. We do not treat pregnant women at the moment because we have no experience about the efficacy of these drugs in pregnancy and the side effects during pregnancy. And we treat carefully patients with cardiovascular disorders. There's no sign or no evidence that these drugs are dangerous, but we have only a very poor knowledge about this connection between cardiovascular and CGRP antibodies, so we are careful in this patient group. We have now 3 different CGRP antibodies coming on the market. At least in Germany we have them available, so we treat all patients with all these 3 antibodies. There is no clinical or whatsoever evidence which of these antibodies is the best. We believe that they are all working about the same, have the same efficacy, but there might be some patients responding to one better and other patients responding to another better. So we first try one CGRP antibody. If it works, it's fine. If it does not work, you can change. The new CGRP antibodies are antibodies. This means they interact with the immune system. And what we do not know now is, will there be any long-term effect on the immune system? And I think it will take 5 to 10 years before we know this answer.